Hello everyone and welcome back to my channel. So today's topic is the chapter of bones, and before I start this chapter I want to give a few disclaimers. Number one is that this chapter has got an overlap with orthopedics. Okay, now there are some of the few important topics in this chapter which I've kind of tried to address, and I've also incorporated inputs from other sources, essentially the pathology outlines, because I feel that if you only read the topics from Robbins, then you may miss out on certain important points and important concepts. So I've only tried to highlight the important areas in this chapter, and I've tried to put the inputs of this chapter from different sources together at one place. So I'm going to take you through Robbins, of course, and the important tables of Robbins. Along with that, I also have a few handwritten notes and the images. So we are going to do all of it together so that you get the important points from the perspective of pathology. Obviously your concepts will get more strong once you complete the subject of orthopedics, but this video is essentially dedicated keeping in mind the aspects of pathology only. So without further ado, let's dive straight into this chapter. So the basics has to be clear. So there are three kinds of cells: osteoblasts, osteocytes, and osteoclasts. Important to understand is that the function of osteoblasts is osteoid matrix synthesis, which means that osteoblasts will synthesize bone, right? So in the disorders in which there is dysfunction or dysregulation of osteoblasts, or rather the osteoblastic tumors, where the action or activity of osteoblasts is increasing or dysregulated, in those disorders you will see that there is an increased bone deposition, and that increased bone deposition is either neoplastic in the neoplastic disorders or they are disorganized in the metabolic disorders. So this is an important concept, that whenever you will find osteoblastic disorders or osteoblastic diseases, in those tumors the bone formation will be present or will be rather increased. Okay, now if you talk about the osteocytes, they help in mechanotransduction, a process which regulates the calcium and phosphate levels. Osteoclasts help in bone resorption. So whenever there is an osteoclastic defect, the bone will not be resolved and therefore the bone will keep accumulating, ultimately giving rise to sclerosis, right? So here I've just tried to brush up the important points as I mentioned, keeping in mind the perspective of all categories of students. So this is an important point, that the balance between the bone formation and bone resorption is modulated by rank and WND signaling. Important MCQ. I will just take you through this image which is there. Now you must understand that osteoblast is having a rank ligand. So rank ligand is present on the osteoblast and the rank receptor is present on the osteoclast. Okay, so there is interaction between these two which helps in activation of this NF kappa beta pathway, and there's also action of this macrocyte colony stimulating factor, all of which ultimately leads to differentiation into an osteoclast. So this is an important point, and osteoprotegrine is something which blocks this rank ligand interaction. Now I will just take you through these disorders and the basic understanding mechanism, because these are confusing. So once you know the basic pathogenesis, it will also be easy for you to read the orthopedics. Now what is osteogenesis imperfecta? यहाँ पर क्या होता है? There is deficiency of the type 1 collagen synthesis because of the mutations in the genes encoding alpha 1 and alpha 2 chains of the type 1 collagen, also known as the brittle bone disease. Important point: autosomal dominant inheritance, the bones are extremely brittle, and there's also blue sclera and hearing loss. The type 2 is more fatal in utero, the type 1 is comparatively better in that way. Now this is a very important chart. Okay, here all the disorders along with the genes is present. Now all of which you can't remember, I'll just mention the important points. Cleidocranial dysplasia run next to important, Holt-Oram syndrome TBX5 important, achondroplasia FGFR3 important, hypochondroplasia has the same gene defect. Now osteopetrosis, autosomal dominant and infantile form. So osteopetrosis is having both the forms. In the autosomal dominant you have the LRP5, infantile you have the rank ligand. Very very important question. Now achondrogenesis, a type 2 called 2A1, then osteogenesis imperfecta type 1 to 4. In all of this You have the col1a1 and col1a2, which means the collagen 1 is getting affected here, as you can see. So which collagen is affected in which disease, this is important, and based on that the genes are named. Osteopetrosis with renal tubular acidosis, very important. Osteopetrosis is also associated with something called as renal tubular acidosis, especially in those in which there is mutation in the carbonic anhydrase enzyme gene, which is the CA2. Okay, and osteopetrosis, the late onset type 2, is having a defect in the chloride channel. So osteopetrosis is having two forms. Number one is where there's defect in the carbonic anhydrase enzyme, and where there's defect in the chloride channel. So these are the genes which are important. So this part is the most important, and I've just told you the important points. You can just go through this. You can also go through this, but then I don't think this is much important. This part is what you should be able to remember, not all of them, the ones only which I've highlighted. Now, what is osteopetrosis? Osteopetrosis is a condition where there is reduced bone resorption because of the defect in the osteoclast. So I've just explained you that osteoclast means it will resorb the bone, it will break down the bone, but because of the osteoclastic defect, the bone is not getting resorbed, and because of this reduction in the bone resorption, there's going to be an increase in the bone deposition, leading to symmetric skeletal sclerosis. Okay, the mutations over here interfere with the acidification of the osteoclast resorption pit, which is required for the dissolution of the calcium hydroxyapatite within the matrix. In the Albers-Schonberg disease, the mutation is in the chloride channel, which I have mentioned. Now, along with that, there's also mutation in the TCIRG1 gene. And yes, I have mentioned about the carbonic anhydrase enzyme defect. Along with that, there's also mutation in the IKB-KG gene, which encodes NIMO, which is a regulatory subunit of the inhibitor of the kappa beta kinase complex that is involved in the NF kappa beta activation, which is a cause of osteopetrosis that is not due to defective acidification. So whenever there is defective acidification, then the carbonic anhydrase enzyme is involved, and it is also involving the renal tubular acidosis. It is number one type, and number two is where there is defect in this gene, which is ultimately causing the process of osteoclastogenesis. But here there is no defect in the acidification. Okay, now this is again an important chart. There are four types of osteogenesis imperfecta. In most of them, you will find that there is defect in the pro-alpha 1 and the pro-alpha 2 chains. In type 1, there is defective synthesis and abnormal chains. Whereas in type 3, you will see that the structure of these chains is getting altered. So most of them is having autosomal dominant, but there's also few where you will find autosomal recessive inheritance. So osteogenesis imperfecta is not only having autosomal dominant inheritance, it's also having autosomal recessive kind of inheritance. So these are important points. You can just go through it. You can also go through this, but I feel that this part is most important. So continuing with the osteopetrosis, as I was talking about this, you can see that here what you find is called as Erlenmeyer-Flusk deformity, important MCQ. Okay, and because there is so much of bone deposition because of the reduced resorption, you know, this neural foramina is becoming small because there is so much of deposition of the bone, and therefore it can also compress the nerves. Now, the next point I will talk about is the Paget's disease. I'm just going through the basics of this. You see that there is an increased and disordered, structurally unsound bone mass. There are three stages here: initial osteolytic stage, then osteoclastic, osteoblastic stage, and a burnt out osteosclerotic stage. So both kind of cells are involved. The osteoblast and the osteoclast both are involved. In the first stage, you have the action of the osteoclast in the osteolytic phase, after which there is a new bone formation by the osteoclast and the osteoblast interaction, which is in the mixed phase, after which you can see that this bone is so haphazard, it is so disorganized, right? So basically there is mutation in the SQSTM1 gene, which increases the NF kappa B activity, which enhance the osteoclastic activity. The rank mutations are also important questions. Okay, and the most important hallmark is that, you know, the type of bone deposition that you find here is the jigsaw puzzle appearance produced by the unusually prominent cement lines. So as you can see here, there is so much of bone deposition by the osteoblast that it ultimately gives a mosaic appearance. You can see this bone formation is having a mosaic appearance, right? So this word is important: jigsaw puzzle like appearance of bone deposition. The osteoclasts are abnormally large. They have so many nuclei, and the osteoclasts, they also persist in the mixed phase, but many of the bone surfaces are also lined by plump osteoblasts. So osteoblasts, osteoclasts, both of them has got activity over here. Now the clinical features are also important. There's enlargement of the craniofacial skeleton, which produce a lion face, and the cranium is so heavy that it is difficult for the person to hold the head erect. So sad, no? The weakened pagetic bone may lead to invagination of the skull base, platybasia, and compression of the posterior fossa. Weight bearing causes anterior bowing of the femur and tibia and distorts the femoral head, resulting in severe secondary osteoarthritis. So all these are important points. Another important point is that there is something called as high output cardiac failure, because this hypervascularity of the Paget's bone, they act as arteriovenous shunt, which leads to high output cardiac failure. Very important point. Now, healing of fracture is a long answer question for all categories of students. You just would need to know this. There's not much concept. I will just go through it. That initially what happens is there's formation of something called as hematoma after the injury. This clot provides a fibrin mesh which seals the fracture site and provides a framework for the inflammatory cell influx, fibroblast in growth, and capillary proliferation that characterize the granulation tissue. So slowly there is formation of the granulation tissue, which will release the PDGF, TGF beta, and FGH. These are the things which are released by these degranulated platelets and inflammatory cells, which will ultimately activate the osteoprogenitor cells, which will stimulate the function of osteoclast and osteoblast. Ultimately, this formation of soft tissue callus or something called as a procallus. Now, this procallus will now ultimately get converted into a bony callus. Within the second week, this activated osteoprogenitor cells will deposit the subperiosteal trabecule of woven bone oriented perpendicular. So now there is deposition of this woven bone, which is deposited in a perpendicular manner, and this process will transform the procallus into a bony callus. Okay, fine. After that, there will be activated a soft tissue mesenchymal cells, which will also differentiate into chondrocytes, which will produce the fibrocartilage and the hyaline cartilage. So now this callus is ultimately getting converted into a bone. Enchondral ossification produces a continuous network of bone and bony trabeculae. Now, this fractured side will be ultimately breached, and there's progressive mineralization. The stiffness and strength of the callus will start to increase, and there will be excess fibrous tissue, cartilage, and woven bone, which is produced ultimately, which will be resorbed. These things will ultimately get resorbed as the callus will mature, which will reduce the size of the healing bone, and it will recreate the lamella bone. From the procallus to the callus, ultimately this woven bone is getting converted into a lamella bone, which is causing the healing. Now, most importantly, coming to osteomyelitis, important point is that this is something which I will explain from my notes also, but I'll just want to mention here that how does these organisms reach the bone? They mainly reach the bone by the hematogenous spread. So you know that in the osteomyelitis, first the organisms have to have access to the bone. So how do they reach the bone? They mainly reach the bone by hematogenous process, okay, especially in the children, okay. But in case of the adults, these organisms will reach because of the complication of an open fracture, surgical procedure, or infection in case of diabetes. So all these are methods by which these organisms is ultimately reaching the bone. And once they reach the bone, how the exact pathogenesis occurs, I'm going to come to it now. So if you see the osteomyelitis, so now after this septicemia or the injury, there is going to be stasis of blood due to hairpin capillary arrangement of the metaphysis. So if you see this is the bone, then in the metaphysis you have this hairpin like arrangement of the capillaries. Okay, you see that this is so complex, and this is a hairpin arrangement. And because of this hairpin arrangement, you can see that there's stasis of blood. So because of this special arrangement, there's going to be stasis of blood in this area, which is the metaphysis. And once the blood accumulates over here, there's going to be acute inflammatory reaction. So essentially this happens because of the hairpin like arrangement at the metaphysis, and therefore metaphysis is the site where this is actually taking place. Now once there is acute inflammatory reaction, there's going to be spread of infection into the shaft bone, and after this spread of infection, this infection will also now proceed to the periosteum. So if you see, this is the bone, this is the periosteum. So once this infection reaches the periosteum, this periosteum will now become elevated. So you can see this area, the blood supply will be cut off, right? So there is lifting of the periosteum, impairment of the blood supply, and because of that there is going to be segmental bone necrosis, which is called sequestrum. So sequestrum is the dead bone which is formed because the blood supply is no more there. Now further this will be again lifting the periosteum and ultimately rupture of periosteum and the formation of a draining sinus. So once this periosteum ruptures, this is formation of a draining sinus, and what happens ultimately is that after the first week, the chronic inflammatory cells will increase and they will release the cytokines which will stimulate the osteoclast activity and the bone resorption, and at the same time there will also be deposition of reactive bone in the periphery. So this is the most important part, that ultimately there is also deposition of new bone. This is what you see in the x-ray in case of acute osteomyelitis, and this new bone which is formed in the periphery is living bone which is known as involucrum. So you get involucrum, which is living bone, and sequestrum, which is dead bone in osteomyelitis. Now what you see exactly is that there are two kinds of osteomyelitis. One is the acute, one is the chronic one. So acute में क्या होता है, you have in the X-ray you will see that there is a new bone deposition, but in the chronic you will see that there is thickening of the cortex, sclerosis, sequestrum, involucrum. These things you are going to find in case of chronic osteomyelitis. Now if you see the clinical features, the acute one is going to have an acute onset of pain, swelling, fever, etc. But in the chronic osteomyelitis, you will just have a chronic discharging sinus. You will not have this inflammatory symptoms. So in case of chronic osteomyelitis, it is just the discharging sinus. Along with that, sometimes there is tenderness on deep palpation. But the acute ones, you will see that there is so much of fever and all these signs of inflammation will be present here. Now, if you talk about the complications, in the acute ones will sometimes get converted to chronic. Acute pyogenic arthritis can also happen, pathologic fracture, growth plate disturbances, sinus tract malignancy. In the chronic osteomyelitis, you will have episodes of acute exacerbations where the patient will again present in a febrile state. There may be growth abnormalities like shortening, lengthening, deformities, pathological fractures, joint stiffness, etc. The organisms involved are the Staphylococcus aureus, most common. In case of neonates, Haemophilus influenzae. In case of sickle cell disease, Salmonella. In case of genitourinary infections, E. coli. So this is the end, and now coming back to Robbins, I was talking to you about all these points. Now important thing is this chart. Now there are some cartilage forming tumors, some bone forming tumors, tumors of unknown origin, and notochordal tumors. Very important chart, because you need to know which are the tumors which are cartilage forming, which are the tumors which are bone forming. So bone forming can you tell me which is the cell which is involved here? I have already mentioned it is the osteoblast, which is defective, which is functioning more over here, because of which there is bone formation. So which are the osteoblastic tumors? They are the osteoma, osteoblastoma, and osteosarcoma, out of which osteosarcoma is malignant. So you must know which is malignant and which is benign. Very important. Now, cartilage forming tumor, they are the osteochondroma, chondroblastoma, and chondromyxoid fibroma, and chondrosarcoma. Chondrosarcoma is the malignant counterpart. So this is malignant, this is malignant, this is malignant, and this is malignant. Very important. Unknown origin, benign में giant cell tumor, aneurysmal bone cyst, and malignant में you have the Ewing sarcoma and adamantinoma. Chordoma is also malignant, rising from the notochordal cells. So in this chart you will see the locations are also present. So this chart is very important, right? So you see most of them are present in the metaphysis area, but chondroblastoma is present in the epiphysis. Very important differentiating point. So all of which are important. Ewing sarcoma is more common in the diaphysis, right? So don't get confused. Giant cell tumor, epiphysis, metaphysis also. So these points are important. Please go through this chart. Last minute revision for your MCQ based exam. Now coming to osteoid, osteoma, and osteoblastoma, the differentiating point is that osteoma will respond to NSAIDs and aspirin. Why? Because they're present with nocturnal pain, which is due to the prostaglandins, which is produced by the proliferating osteoblast, and therefore it can be relieved by aspirin and other NSAIDs, but osteoblastoma do not respond to aspirin or NSAIDs. Okay, now they are larger than 2 centimeter. They typically involve the posterior spine, laminae, and pedicles. Very, very important points. It can cause pain, but which is unresponsive to aspirin, and they do not induce the reactive cortical bone. So this entire paragraph is important from the point of view of MCQs. Now, osteosarcoma, very, very important points. Malignant, very important, bimodal. Okay, and it also has got association with the Paget disease. Now, this pathogenesis is important. All these important genes are involved. The RB mutations, TP53 mutations, the CDKN2A mutations, MDM2 and CDK4. All these are important gene mutations which help in the pathogenesis of osteosarcoma. In this, you can find, this is the Codman's triangle. As you can see, there is elevation of the periosteum with deposition of this reactive bone, and this is ultimately forming a triangle like this. Now I'm going to talk about this in detail from my notes, but these are the important points I've just highlighted over here. So I'm just going to show you this. Now if you see this, these are the neoplastic bone which is getting deposited in case of osteosarcoma. You can see that these cells are so anaplastic, and this is a mitotic figure. So coming to osteochondroma, osteochondroma is known as exostosis. It is having a bony stalk which is covered by cartilage. Autosomal dominant multiple hereditary exostosis syndromes can also happen. The genes mutated are the exit1 and the exit2 genes. As you can see that this is the osteochondroma, and this is the hyaline cartilage or the cartilage cap which is seen over here. Okay, this is having a disorganized growth plate like cartilage. Now chondroma, this is a benign tumor again. You can see that the Olier's disease, the Maffucci syndromes are having multiple enchondromas. The mutations involved are the IDH1 and the IDH2. The individuals with Maffucci syndrome can develop multiple enchondromas and spindle cell hemangioma, and are also at risk of developing other malignancies. Important point. Chondrosarcoma, obviously malignant cartilage producing tumor. I'm going to show you this. I'm going to show the images as well. So please wait for the understanding part. The genes involved here are the exit genes IDH1, IDH2, and the CDKN2A. All these are important points. What are the types of chondrosarcoma? Conventional, dedifferentiated, clear cell, mesenchymal. All these points are important. So you can see this is the image which is the chondrosarcoma, and as you can see that these are so many anaplastic cells which is seen in the grade 3 chondrosarcoma. So now let's come back to this, which is the important part. So giant cell tumor, I'm going to discuss all these entities which are important, and I'm also going to show you the images. So let's start this now. Giant cell tumor, it is benign but locally aggressive. Now it is benign, but what is the criteria when you can suspect it's malignant transformation? When you will see this pleomorphism, increased mitosis, reduction in size and number of the giant cells. Now in the microscopy, you can see that there is a neoplastic mononuclear stromal cells and osteoclastic giant cells. So there are two components. Number one is the osteoclastic giant cells. That is why it is called as giant cell tumor or osteoclastoma. Along with that, you also have the mononuclear cells in the stroma which are neoplastic. So if I just show you this image over here, you can see that these are the giant cells, right? And this area is the stroma, where you will see that these are the mononuclear cells. So you can see this part is the stroma. These are the mononuclear cells, but all of which you can see that they are neoplastic. Okay, so the mononuclear cells are neoplastic, which are present in the stroma, and you also have these giant cells over here. Now I just want to tell you here itself that giant cells are not only present in giant cell tumor, they are present in multiple other entities. One important point to understand is that in the case of aneurysmal bone cyst, you will find that these giant cells are present, but along with that, there are cystic spaces filled with blood. So if you see a picture in which there are so many cystic areas filled with blood along with giant cells, it is aneurysmal bone cyst and not giant cell tumor. I'll just take this moment to compare this topic with you. Aneurysmal bone cyst, the gene involved is USP6 gene 17p chromosome. it is a benign multiloculated blood-filled cystic lesion of the bone. So you can see here that there are so many giant cells over here. As you can see, their stroma is also having stromal cells, mononuclear cells, but the presence of these cysts along with this hemorrhage is something which can be seen in case of aneurysmal bone cyst and not a giant cell tumor. As you can see over here, these are also cystic spaces, right? So this is just a difference I wanted to highlight. Now coming back, this image also shows the same thing in the low power. So basically the important features that I'm trying to highlight here is that it occurs only in a closed growth plate, eccentric location of the tumor, well defined with non-sclerotic margin, so bubble like appearance, very important in the x-ray, subarticular location just below the joint, very important, expansile. The important negative points are that there is no calcification, no newborn formation, it does not involve adjacent joint. So the defect in the giant cell tumor is the defect in the osteoclast, right? And therefore there is no newborn formation, because newborn formation was a feature in the osteoblastic tumors and not the osteoclastic tumors, right? So I hope you are getting your concepts clear now. The location involved is metaphysis, epiphysis, distal femur proximal tibia, sometimes in the axial skeleton in the proximal sacrum. Now, this is the important point. What are the other lesions which contain the giant cell? Number one, giant cell tumor, simple bone cyst, aneurysmal bone cyst, chondromyxoid fibroma, benign chondroblastoma, brown tumor of hyperparathyroidism, non-ossifying fibroma, and giant cell wrist osteosarcoma. Pathophysiology, I have already told you that this neoplastic cell will express the rank ligand, which is an activator of the NF kappa beta pathway, and which will secrete various chemokines and cytokines, which will be recruiting the monocyte and the multinucleated giant cells, which is a process of osteoclastogenesis. Along with that, there is also epigenetic histone modifications, activation of the WNT beta-catenin pathway, TP53 and HRAS are also mutated here. The mutation, important point, the mutation here is H3F3A. Okay, so the positive IHC stain here is the H3G34W, right? So important point, this is more important for the postgraduates, that H3G34W is positive here, but it is negative in case of aneurysmal bone cyst, right? So Hg34W is negative here, but this is a positive over here. Okay, and negative is this stain. So this is an important point. Now what are the types? The types are conventional, malignant, and denosumab treated GCT. So I just wanted to highlight one important point over here, that in case of GCT you will see that this rank ligand is important. The osteoblast precursors will express the rank ligand, which promotes the proliferation of the osteoclastic precursor and their differentiation into the mature osteoclast. This absence of normal feedback will ultimately result in localized but highly destructive bone resorption. And the most important point here is that the rank ligand inhibitor known as denosumab, important MCQ. And therefore there is also a kind of GCT which is known as denosumab treated GCT, in which you will find that the osteoclasts are depleted. So we are done with this. Now coming to chondroblastoma, as I mentioned here, that it is a cartilage forming tumor, right? So this will form the cartilage. So there are sheets of chondroblasts which are admixed with giant cells, and eosinophilic chondroid matrix is always present. So giant cells are also present over here, but the important point is that there are sheets of chondroblasts which are present, and the matrix is always pink, means which is eosinophilic, it is rather not blue. Okay, now here epiphysis is a more common important point. Chicken wire calcification, K36M mutation is benign. The nuclei are oval, hyperlobulated. These are the positive stains and these are the negative stains. So if you can just see this, this is a giant cell, fine, but these are the chondroblasts, right? So this is chondroblastoma. As you can see over here that there is deposition of this cartilage present along with this chondrocytes. So this is chondroblastoma, it is benign. Similarly, you will also see that chondrosarcoma is there, where again this kind of cartilage deposition is going to be there. As you can see that there is so much of cartilage deposition here. So what happens is there is abundant cartilaginous matrix with chondrocytes embedded in the lacunae, but there are three grades over here. Grade 1 is minimal cellularity, nodular growth, and grade 2 is moderate cellularity with the diffuse growth. Grade 3 is high cellularity with the marked atypical cell and pleomorphic appearance and mitotic figure. So as the grades increases, the cellularity will also keep increasing. So if you can see this, what kind of cellularity you can see here, I would say like kind of moderate like that. So this can be a type 2 grade. Okay, now difference from chondroma is that this kind of malignant tumor has got cortical expansion, a soft tissue extension, and the size is more than 5 centimeters. For obvious reasons that this is malignant. So you can see here that there is so much of cartilage deposition in this kind of malignant tumor, which is chondrosarcoma. This one I've already explained. Right, now coming to osteochondroma. This is also benign, and the tumor is composed of a stalk of mature bone with cartilage cap. So what you can see here is that this is basically the cartilaginous cap, right, and below which you can see that is the mature bone which is there, and in this area there is also some marrow elements. So three points: marrow elements along with the mature bone, along with this cartilaginous cap. The diagnosis is osteochondroma, right? So I mentioned that over here. The mutations are there in the exit 1 exit 2 genes in the metaphysis region, but this is a benign tumor. But when do we suspect malignancy? When there is a thickening of the cap which is more than 2 centimeter. Very important point: more than 2 centimeter the cap, we can say that there is malignant transformation. There is also similar image, cartilaginous cap along with the mature bone. You can also find these marrow elements in between. Now, fibrous dysplasia, it is a benign entity. There is another entity called as osteofibrous dysplasia, which is again a differential diagnosis. Very important differences are there. So, what is happening here basically is that there is proliferation of the irregular woven bone trabeculae, right? There is proliferation of the irregular woven bone trabeculae. Basically, there is deposition of branching and anastomosing irregular trabeculae of woven bone in a Chinese letter pattern. So you can see here that there is deposition of this bone in a Chinese letter pattern over here. Okay, these are the woven bone which are irregularly and haphazardly deposited. This is fibrous dysplasia. But the important point is that there is no osteoblastic rimming. Can you see any kind of cells? I know this is a little bit hazy, but please try to understand and figure out that. Can you see any kind of osteoblast which is surrounding this woven bone? There is no osteoblast which is surrounding this woven bone. So this is absence of osteoblastic rimming. There is no osteoblastic rimming surrounding the woven bone in case of fibrous dysplasia. But if you see this image, in this you can see that there is presence of this osteoblasts rimming. You can see this osteoblasts. See, this osteoblasts are rimming this woven bone, right? This osteoblastic rimming here, it is present. You can see all this are osteoblastic rimming which is present, but it is not there in this diagram. Can you see any kind of lining over here? By osteoblasts, no, but you can see it over here that this so beautiful lining is present, right? So this is osteofibrous dysplasia. So in case of osteofibrous dysplasia, you have this osteoblastic rimming which is present. Okay, but in fibrous dysplasia it is absent. This is the most important differentiating point. So here you can see that there is no osteoblastic rimming. It is having a kind of woven bone, irregular woven bone which is present there, and the background is having bland spindle cells. In the background you can see all this is the background. This light pink color is the background. You can see that there is bland spindle kind of cells which are present in this stroma. The spindle cells are not atypical. They are just having bland cytological features. Now it is that there are two types: monostotic, means involving one bone, and polyostotic. GNAS1 mutation, gain of function mutation, very important point. Overexpression of the GS alpha protein which disturbs the osteoblast differentiation. Now important point to understand here is that there is bone deposition, there is woven bone deposition, and therefore this is basically because of the osteoblastic defect, right? I mentioned this previously also. So Positive stain is the SAT-B2 and negative is the keratin. Now, important point is that in case of osteofibrous dysplasia, I've already mentioned that osteoblastic rimming is prominent. This is the most important difference from the fibrous dysplasia. Another important difference is that there is something called as zonation pattern which is present in osteofibrous dysplasia, which is a characteristic feature of osteofibrous dysplasia. Now, what is zonation pattern? This means that the bony trabeculae are immature and thin in the center, and they become thick and more mature towards the periphery. So here also there is deposition of woven bone, but this bone is deposited in a very thin manner, in an immature manner in the center. But as we move towards the periphery of this lesion, we find that the bone deposition is much more thick and more mature. This is called as zonation pattern. So you can see here in this image, see the center is having so thin deposition of bone, but towards the end and towards the periphery you see that the bone deposition is so thick and so mature, right? So this is the zonation pattern. I hope you understood this. So now you can tell me that these two images are of what? Are of fibrous dysplasia, okay, and these two images are of what? Of osteofibrous dysplasia. So what are the two important differences I mentioned? Number one is the osteoblastic rimming and number two is the zonation pattern. So what are the differences of fibrous dysplasia from osteofibrous dysplasia? Number one, it does not have a zonation pattern. So fibrous dysplasia does not have a zonation pattern. There is a no maturation to lamellar bone. The fibrous dysplasia bone is always woven. It will never transform to lamellar bone. Okay, and there is no osteoblastic rimming. There is no keratin positive cells in the stroma. In the osteofibrous dysplasia, there may be some keratin positive cells as well. And the presence of a gene as mutations is very important in fibrous dysplasia and not in osteofibrous dysplasia. Now coming to osteosarcoma, very important topic. It is a malignant tumor of the connective tissue which is the mesodermal origin. The tumor produces bone or osteoid because it is a defect in the osteoblast. So it's an osteoblastic tumor. It will produce the bone. Now there are two types, primary and secondary. Primary means there is no history of any pre-malignant condition, but secondary means there is presence of history of pre-malignant conditions like Paget's disease, fibrous dysplasia, etc. Now, these are the histologic types. You have the osteoblastic type, chondroid type, fibroblastic type, osteolytic type. Most common is the knee joint, which is the metaphysis, and they spread in the medullary cavity. They spread by the hematogenous spread as well. These neoplastic bone which is deposited, they are dense, lace-like. The tumor cells have hyperchromatic nuclei. The tumor giant cells are seen, and they are aggressive. They have metastasis, which can be kind of measured by this serum alkaline phosphatase test. Higher value after initial lowering will point to metastasis or recurrence or residual tumor. The X-ray findings are very important. The two most important X-ray findings. Number one is the subperiosteal new bone formation. As I mentioned, that if this is the periosteum, if you have subperiosteal new bone deposition, this ultimately rises and this forms something called as the Codman's triangle. So that's an important point. Next is that the new bone laid down along the blood vessels growing centrifugally will give rise to a sunray appearance. So because of this bone deposition, again the main pathology is that there is bone deposition. So whenever this bone deposition will happen along the blood vessels, so this will ultimately give rise to what? Sunray appearance, because we can see in the X-ray, we can see the bone deposition as calcification. So this is the blood vessel, and if this is the bone deposition happening along with that, so you can see that it's ultimately giving rise to a sunray kind of an appearance. So these two are important X-ray points. Now there are other points of Codman's triangle as well. Codman's triangle is not only found in osteosarcoma but also in Ewing sarcoma and also in subperiosteal abscess. And what are the other osteoblastic tumor in which there is deposition of bone formation? Number one is osteoma, osteoblastoma, osteochondroma, and osteosarcoma. So I've already mentioned about this point before. This is just a revision for you. Now this is a one step higher, rather important for the postgraduates. The different kinds are that there is conventional central osteosarcoma, which is the most common type, then the low grade central osteosarcoma, perosteal and periosteal and high grade surface osteosarcoma, and secondary osteosarcoma. All these are important types. Now important point is that this low grade central osteosarcoma and perosteal osteosarcoma is associated with MDM2 amplification. Very important point. MDM2 amplification is seen in case of low grade central osteosarcoma and perosteal osteosarcoma and not in the others, right? As you can see that in the high grade you have no MDM2 amplification. Now, in case of conventional, this is intramedullary sarcoma. The tumor cells have a high grade atypia and atypical mitotic figures are also present. In case of low grade, there's predominantly fibroblastic osteosarcoma with mild nuclear atypia. So here they have high grade nuclear atypia and here they have mild nuclear atypia. Parosteal means they have a low grade spindle cell tumor, okay, and periosteal means they have an intermediate grade, often with chondroblastic features. Chondroblastic means there is deposition of chondroid matrix, which is the kind of cartilage deposition. Now, next point is osteosarcoma is associated with these genetic syndromes: Lee-Fromeni, hereditary retinoblastoma, Bloom-Richardson, Rothman-Thompson-Werner syndrome. Now, important features about this conventional central osteosarcoma is that there is kind of bone destruction. Yes, there's bone destruction, and they have aggressive periosteal reaction. The bone deposition over there is very aggressive, because of which we have the sunburst type or the sunray appearance, Codman's triangle, and the lamellated or the onion skin reaction. These three are found in osteosarcoma. Very important MCQ as well. Okay, there's tumor matrix ossification and soft tissue involvement. Now, the prognostic factors in case of conventional osteosarcoma, you see that the poor prognostic factors are when there's metastatic tumor, axial tumor site, not the extremities, axial skeleton mein agar hai, then it is a poor prognostic factor. Age less than 14 years old, high serum alkaline phosphatase, tumor volume more than 200 ml, older chemotherapy protocol, inadequate surgical margin, poor histological response. Coming to the microscopic features, just a brush up of the conventional type, you see this permeative growth, intramedullary permeative growth is seen, and cortical destruction is present. Neoplastic cells are having a marked atypia. Now, this neoplastic bone is basically laid down in a filigree or a lace-like disorganized pattern. Now, what is normalization and what is scaffolding? Normalization means there is decreased cytological atypia of neoplastic cells entrapped in the bone matrix. So, if the neoplastic cells are entrapped inside the bone matrix, then the cytological atypia will be less. Okay, that is normalization. And what is scaffolding? Deposition of neoplastic osteoid on the native trabeculae. So whenever there is deposition of this neoplastic osteoid in the native trabeculae, it is known as scaffolding. These are important points seen in case of conventional or high grade osteosarcoma. Now, if you talk about the histologic subtypes, then this osteosarcoma is again having further subtypes. It can be of the osteoblastic type, chondroblastic type, or fibroblastic type based on the kind of matrix that they secrete. In case of osteoblastic osteosarcoma, the predominant matrix synthesized is the bone. So osteoblastic में bone deposition होगा, ठीक है. Chondroblastic में the kind of matrix deposited is high grade cartilage. Okay, they do not have a low grade cartilage. There's always a high grade cartilage deposition. In case of fibroblastic osteosarcoma, the deposition is basically fibroblast or so spindle to epithelioid cells. Telangiectatic osteosarcoma, obviously deposition of this blood filled spaces. And these are the other morphologic variants. You can also have giant cell rich variant, epithelioid variant, osteoblastoma like variant, chondroblastoma like variant, chondromyxoid variant, clear cell variant, small cell variant. So these are all the histologic type based on the kind of deposition that is happening. So this is a kind of an image that you can see. There are so many atypical spindle cells that you can see, which is producing this immature and lace like bone. And here also you can see that there is deposition of this immature bones. See, the image is so grossly looking ugly image, so this is osteosarcoma. So this is it. I'm kind of done with this chapter. So I've tried to incorporate the important points, keeping in mind the concepts, the viewpoint from pathology, and keeping in mind all categories of students. So I hope that this could be of some help to you. I will come back very soon with my next topic. So if you have any personal query, you can mention down in the comment section below. If you like my content and my effort, then please consider subscribing. I will appreciate your valuable feedback and inputs into my work. I will meet you very soon in my next video. Till then, take care, keep studying, and thank you for watching.